dear chairs, dear audience, welcome to my presentation at this complex exam. The title of my thesis is The Role of Prevention and Early Intervention in Venereal Diseases. My name is István Szondi. I'm a medical doctor and a full-time PhD student at the dermatology clinic. First, let me share my vision with you, which is proactive care to prevent STIs and reduce complications. To realize this vision, my mission is to introduce prevention and early intervention in the clinical practice. For this, I have 3 projects right now, and in my first project, which is investigating the efficacy and safety of doxycycline in preventing sexually transmitted diseases, I conducted a systematic review and meta-analysis with the help of my team. Sexually transmitted infections pose a global threat, as there are more than 1 million new cases of bacterial STIs diagnosed every day worldwide globally. Now, these infections are curable, but they have to be caught early, which can be challenging due to reluctance to seek help at asymptomatic infections. Untreated patients infect others, while the initially curable disease causes irreversible damages to the body. To prevent this, a novel approach is to administer doxycycline as a prophylaxis. Treponema pallidum and Chlamydia trachomatis are generally sensitive to this agent, while Neisseria gonorrhoeae shows low to moderate susceptibility. In a low dose, it is considered to be safe, so the question remains whether it is effective enough to prevent STIs, which was our goal to assess. And for this, we used the PICO framework. Our population of interest was sexually active adults, and we compared doxycycline pre-exposure prophylaxis or doxycycline post-exposure prophylaxis to no prophylaxis. Our primary endpoint was the incidence of bacterial STIs, while we had 3 additional secondary outcomes: adverse events, antimicrobial resistance, and adherence to prophylaxis. We hypothesized that the use of doxyprep and doxypep can reduce the new cases of these bacterial STIs. And here on the first forest plot, you can see the results for the primary outcome presented. You can see on the forest plot, you can see the total number of visits and the number of visits with an STI event in the doxyprophylaxis and in the control arms expressed as incidence. We included a total of 6 randomized control trials, of which 4 investigated doxycycline post-exposure prophylaxis, so doxypep. You can see it on the upper part of the figure, and 2 studies investigated doxyprep. You can see it on the bottom part of the figure. Among these 6 studies, 5 studies enrolled exclusively men who have sex with men and transgender women, and only 1 study, the study by Stewart et al., included cisgender women with male partners. The heterogeneity was substantial at 73%, which is mainly due to the study of Stewart, which failed to show any benefit of this doxypep method. However, the overall risk ratio was 0.44, translating to a clinically relevant and statistically significant 56% decrease in the risk of acquiring any STIs with the use of doxyprophylaxis. If we included only the doxypep studies, the risk ratio stayed around the same with 0.47. However, we did not have enough studies to conduct a separate analysis on doxyprep. And here on the next 4 forest plots, you can see the results for doxycycline post-exposure prophylaxis only, including only men who have sex with men and transgender women. As you can see, the decrease in STI rates were significant across all analyses, including the one for gonorrhea in this subgroup. Notably, there was a remarkable 77% decrease in the risk of acquiring syphilis with the use of doxypep, which deserves particular attention due to the serious complications syphilis can cause. As for the secondary outcomes, there was only 1 serious adverse event reported, fixed drug eruption, and 1 study reported poor adherence to the prophylaxis. This was the study by Stewart et al., and this rendered the prophylaxis ineffective. The major concern around this topic is the emergence of new antimicrobial resistance as a result of extensive antibiotic use, yet none of the studies have been able to provide any clear evidence on this matter. We included only RCTs, and this was the first meta-analysis in this topic. However, 2 of 6 studies had not yet been published at the time of our assessment. Only interim data were available. Furthermore, we did not have enough studies to conduct a separate analysis on the doxyprep. In conclusion, our study provided robust evidence that doxyprep is effective in preventing syphilis and chlamydia infections in high-risk MSM and transgender women populations, with potential effectiveness against gonorrhea likely dependent on local resistance patterns. The continuous monitoring of the resistance issue will be key in the future, as the impact of doxyprep on the emergence of new antimicrobial resistance will determine its long-term applicability. Based on our results, we advocate for the use of doxyprep in high-risk MSM and transgender populations with careful patient selection. However, additional studies should investigate doxyprep and doxyprep in cisgender women and in men with female partners to ensure that these findings are applicable to a broader demographic. Our paper was accepted and published by the International Journal of Infectious Disease, and now let me present you my second project, which investigates the potential role of meningococcal vaccines in the prevention of gonorrhea. The growing number of multi-resistant strains of Neisseria gonorrhea is an emerging problem, and despite the attempts, there's still no available vaccination. On the other hand, we have several safe and effective vaccines to prevent meningococcal disease. Neisseria meningitidis, a bacterium from the same genus, has very similar outer membrane components, which could be the basis of cross-protection offered by this vaccine. Thus, our goal was to determine this effectiveness of OMV vaccines against gonorrhea. We also used the PICO framework, and the population was anybody eligible to receive meningococcal vaccines, and we compared OMV vaccines to no OMV vaccines, which could be no vaccination at all, or other non-OMV containing meningitis B vaccines as well. Our sole outcome was the incidence of gonococcal infection, and we hypothesized that these OMV meningococcal vaccines indeed provide cross-protection. And on this forest plot, you can see the results for this vaccine effectiveness outcome presented. We compared the incidence of gonorrhea among vaccinated individuals to that in unvaccinated controls. We included a total of 7 studies in this analysis, and the follow-up times in the studies were quite similar, around 2 and 3 years. The heterogeneity was 55%, which is moderate and likely due to variations in study designs and population characteristics. Overall, the vaccine effectiveness was 38%, which was both statistically significant and clinically relevant. The next forest plot suggests that completing the full vaccination series might offer enhanced protection compared to partial vaccination. However, this finding was not statistically significant because we only had a few studies to include in this analysis, and the corresponding sample sizes were quite low. We investigated large cohorts of patients, and the similar follow-up times contribute to the reliability of our findings. However, the presence of only one RCT and differences in study designs and population characteristics limit the generalizability of our findings. To conclude, OMV meningococcal vaccines provide moderate protection against gonorrhea and could be recommended to individuals at high risk for STIs. However, future RCTs with longer follow-up time should be done to establish causality, to determine the length of the protection, and to find an optimal timing for a potential booster dose to extend this duration of protection. This manuscript was published in the journal Vaccine around a month ago, and in my last project, I aim to explore the prevalence of syphilis among sex workers to identify additional vulnerable populations that could benefit from the aforementioned targeted interventions. Beside my work here at this Translational Medicine Center, I teach dermatology to graduate students. I participate in drug trials as a sub-investigator, and I'm also involved in a number of other research at the dermatology clinic. And lastly, I would like to thank you for your kind attention with a quote from John Steinbeck: "It's in the nature of man to rise to greatness, if greatness is expected of him." Thank you again for your kind attention.
antibiotic issue. I mean, this is a big issue today.
Yes.
I mean, there are costs and benefits here. So what is your point?
Yes, it is an issue, and this doxypep method is still being highly debated because of the fear of potential rise of antimicrobial resistance. But I think this potential has to be weighted against its remarkable efficacy. So I would highlight the efficacy against syphilis, so almost 80% against syphilis. If we choose our population well, it could be very beneficial. I think it's very important, first it's very important to narrow it down to a core population. So we wouldn't give it to anybody. At this point we only have evidence for MSM, so we would only give it to MSM. MSM usually at higher risk in general for STIs, and I would set additional criteria, for example, having STI history, being on HIV PrEP or living with HIV infection, and reporting condomless sex continuously. Then I think we could narrow it down to a small subpopulation, and then we won't use that much antibiotic. But another aspect, if we go into details, which pathogens would develop resistance. So regarding STIs, for chlamydia and Treponema pallidum, it's highly unlikely. Due to the 3 decades of tetracycline use, we have not seen any resistance. In theory, it could happen, but it's not likely. Gonorrhea, Neisseria gonorrhea could develop resistance, but it's already there, and we don't use tetracyclines to treat gonorrhea. So the clinical relevance is debatable here. In my opinion, what is most of concern is Mycoplasma, which can be multi-resistant, which develops tetracycline resistance, and we are already facing challenges to fight it. But then again, this concern has to be weighted against this remarkable efficacy.
So what would be the strategy on this? I mean, resistance.
Yes. So I think the first step would be to develop local guidelines. The CDC issued a guideline last summer, but it also suggests countries to develop local guidelines, because local guidelines are of utmost importance here because of 2 factors. First, we need to know the local resistance patterns for gonorrhea, because it's important whether it will prevent gonorrhea or not. And the other one is the incidence of syphilis. So this method is, in my opinion, mainly against syphilis. And in regions where syphilis incidence is low, I don't think it's that important. But in Hungary, we are observing a surge in syphilis cases, for example. In the last 5 years, syphilis cases, incidence of syphilis rose with 40%. So I think developing local guidelines, and in these local guidelines, as I mentioned, we have to set criteria, and clinicians, professionals have to decide these criteria, and we have to set these criteria to include enough patients, but to exclude anybody who is not at that high risk. We have to find the group at the highest risk. I think that's our task for the future.
Very good. I would have more questions, but I think I will just pass around.
Yeah, do we have any more questions from the fellows? I've been told you all have to ask questions. Nobody's forthcoming. I really enjoyed those presentations, both of them. They're both really well done and impactful and published, and that's phenomenal at this point. Yeah, I thought it was intriguing. For most of these MSM high-risk patients, they're going to be taking HIV PrEP anyway, I guess.
Yes. Yes, all of the studies, they included only participants taking HIV PrEP.
So it was the two together. It was an additional add-on onto HIV.
Yes.
Yes. Because that would be one concern, in a sense, that you would take this and think, okay, I'm bulletproof against syphilis and chlamydia, but I actually get HIV because you've forgotten to take that. So I guess that is an important part of it, that it's an add-on, and I guess that people who are used to culturally doing that makes it a bit easier to add it in, and you've already got a receptive patient. How much in the way of patient engagement do you have in those systematic reviews? You know, is there any kind of inclusion in the patient voice in those studies, or is that something that you might do in the next year or two?
What kind of studies?
Well, just to include people who are living with these conditions in terms of the study design, the questions that are important to be asked. Is that part of the philosophy of it?
Which condition? I didn't.
Well, any of these conditions, you know, people who are living with sexually transmitted diseases, or who are your target population for the intervention. You know, are they involved in the design of any of these studies, the systematic reviews and so on?
Oh, yeah, well...
Sorry, maybe I'm not making it clear.
I'm sorry if I understood the question correctly. Yeah, so in the studies, only patients were involved who are either living with HIV infection or taking HIV PrEP. And to my knowledge, there aren't any other studies being conducted with patients who don't qualify for these criteria, just because as you said, we really don't want to risk of them contracting HIV by having an intervention like this.
Yeah. So I think just the applicability of it as you begin to perhaps develop policies, it's important to bring that community in and to say, well, what would this look like in your life, and the acceptability of it, and have them understand the science is really an important way. In many places, that's an important way to get translational grip and for people to start using it.
Yeah, thank you for the question. So this method is already in the media, so it's a very hot topic, not only in the medical fields, but among the MSM and LGBTQ community. And I think, yes, they should be involved in developing the guidelines, but I think it should be done in a way that clinicians might start advising this method using and getting feedback from the patient over time. And also what the CDC guideline recommends is that to cancel high-risk MSM and for it to be a shared decision. And yes, I think feedback from the patients are very important.
Yeah, and I think the doxycycline, we use it a lot for acne still in many parts of the world, so you're probably unlikely to shift the dial too much on antimicrobial resistance. I think, you know, people are on it for 6 months for acne, and in some part, I don't know if you use that in Hungary much for acne, or if you use other tetracyclines, but many countries use doxy because it's so cheap, relatively inexpensive.
Yes.
So it is widely used, it's widely out there, and you're probably not going to really change that dramatically with that. The second paper you produced, which is again really interesting, looking at the meningococcal vaccination for cohorts who've been vaccinated and then their relative resistance to gonorrhea. That's also with the capsule. That's really interesting too. Are you going to recommend meningococcal vaccination? Do you think is there anywhere in the world that's done that so far? Brought it in for high-risk populations for gonorrhea?
Yes, actually I think this method should be rather interpreted on the population level, because this 40% efficacy is not really interpretable on the individual level, because what do we say in the patient? Will it prevent gonorrhea or not? We can't say it. But on population level, I think this 40% is high enough. And actually, England will be the first country to launch a campaign vaccination in August, and MSM will be eligible to participate in the campaign. And there are some very interesting modeling studies, and these modeling studies modeled actually very promising outcomes. So, for example, one study estimated that if MSM presenting on regular screenings, and during 1 year only 30% of these MSM take up the vaccination. In 5 years in England, gonorrhea cases could be reduced with 100,000. So I think it could and should be recommended high-risk individuals, but rather not on the individual level, but in campaigns. because it doesn't really have a side effect. It won't make the bacteria develop resistance. The only limitation is the price. So it's kind of a pricey vaccination, around, in Hungary, at least 1,500 pounds, the 2 shots which is required. And also, I think we would need at least 1 RCT that shows the effects of this vaccine before we launch these campaigns. But I'm really excited about this campaign in England, and it looks promising, and we will see in the upcoming years its impact.
Yeah, it does look, because it's in the primary program now for countries bring it in, of course, at different times, but as a primary immunization series, it's been around for 15 to 20 years in some countries, and maybe, so that cohort of people as they grow up won't need revaccinated. Is that correct?
No, because
or is it a different meningococcal vaccine than they get in the primary program?
No, it's the same. It's the same. It could be the same, but the problem is it looks like the protection against gonorrhea wanes shortly. In 2 and 3 years it wanes. So this primary vaccination program is for children, and there will be no protection against gonorrhea 10 and 20 years later, unfortunately.
So you need a booster vaccine every 3 years potentially?
We don't know that potentially. But then again, there are studies about age-related sexual disease. So among MSM, the MSM below the age of 35, they are at 4 times higher risk than MSM above 35. So it doesn't have to be administered for a lifetime. But there's a phase for everybody when they are at higher risk, 5 years, 10 years, and let's assume it protects for 3 years, then that's 2 booster doses and it's 10 years. So I think it's not necessarily a major problem. Yeah.
So you get another primary 2 shots and then a single shot booster maybe?
Yes, that's what they do against meningitis B, because they suggest booster dose to immune-compromised individuals. For example, someone who had their spleen removed, then 1 shot of booster dose is recommended in every once a while.
Congrats on your wonderful presentation. I would like to have a question about the first topic. So, I was thinking about the false reassurance that taking HIV PrEP and DoxyPrep at the same time would give for the high-risk population, and I would like to hear your thoughts about that.
Thank you for your question. Well, it is of concern, of course, but the thing is, these patients are already at high risk, already being engaged in high-risk sexual activity. So DoxyPrep, I don't think it will make them to engage in high-risk activity even more, but even if so, we can fight against it, because doxycycline requires prescription everywhere. And we can tie the prescription of doxycycline, for example, to regular screening. We prescribe it for 3 months, and then they have to come back to a refill after 3 months, and they have to go under a full panel STI test in order to get the refill. And in this way, we can capture any breakthrough infection, and I think it's feasible this way.
Thank you.
In your second study, you mentioned that the follow-up time was 2-3 years. 3 is 50% more than 2. How can you explain that you can still pool these studies concerning that these are incidence rates?
Thank you for your question. So the follow-up times were indeed 3 to 4 years. 2 to 3 years, yes, but these were retrospective studies and mostly retrospective case control studies. So they set up a time from 2016 to 2019, for example, and they evaluated the participants being vaccinated and contracting gonorrhea in that time. So we don't know the exact follow-up time for patients. We only know the interval, so we only know that they might have been followed to a maximum of 3 years. But there's a possibility they have been followed for 2 months. And this was the same in almost all of the studies. So we didn't have exact follow-up time, and unfortunately that's why we couldn't really guess the length of the protection.
Thank you.
You said that the incidence rate for syphilis increased 40% in the last couple of years. Am I right?
40. 40.
40.
40, yes.
This is a lot. I mean, that what happened? No, I mean, that could be multiple reasons, because maybe the diagnosis is one thing. I mean, that before, so.
Yeah, well, the diagnostic procedures, to my knowledge, haven't changed in the last couple of years, and also chlamydia and gonorrhea cases didn't mimic the rise in syphilis cases, so I'm not sure, but I don't think anybody knows it at this point.
So this is based on Hungarian data?
Hungarian, again, official Hungarian data. Yes, the most up-to-date data is from 2022.
So what happens in other countries? Do you know about this? Maybe not particularly this, but on the long term.
Well, on national level, in the Western countries, the rates of STIs are quite stable and have been quite stable in the last 20 years. A minimal rise could be observed. In small population, for example, MSM populations, there has been a great rise in syphilis cases. But on the national level, I haven't seen data similar to ours.